we as a family, the John Wayne family, knows you for many years because you ran the breast program at the John Wayne Cancer Institute, or yeah, breast program at
Yes.
the John Wayne Cancer Institute years ago, and then we followed you for the last few years as you've moved around, and now we've been able to support your work at Duke University, and we're excited to hear sort of what that's about. And I think, just in layman's terms, that it's, I guess our bodies are sort of designed to heal themselves and keep going as long as we treat them right, and we stay within certain parameters. And if the outside environment or something that we do to ourselves pushes us out of the lane that we should stay in, then we have to deal with things.
Yeah.
And if I'm not mistaken, isn't that the study of epigenetics, and that's what your research is focused
Yeah,
on?
exactly. Yeah. So first, I'm so excited that I know you and I've known you for so many years, and that we're able to continue to work together, and that the John Wayne Cancer Family and Foundation are supporting my research. Very grateful for that, and so thank you, Ethan. But that's exactly right. So this field of epigenetics, I think it's fascinating, and it really only has become kind of a part of um, cancer research, probably just in the last a couple of decades, that we've actually learned that genes can be abnormal, not because they're broken or mutated, but just because they're aberrantly shut off. So if you have a gene that's shut off, it's not going to be functioning just as if it was broken. But in reality, you can turn these genes back on. And so this is kind of the concept of epigenetics, or the study of the changes outside of the gene that influence gene expression. And it can come from exposure to environmental toxins and diet and stress and any number of things that we encounter in our daily lives that we're not really aware of. But what we've actually done with that whole field is we're moving toward looking more specifically at breast cancers, learning about the molecular features of them to try to help us to understand cancers more. How do we treat them? What can we learn from them? So in my field, which is breast cancer surgery, one of the things we do frequently is we remove lymph nodes to see whether or not cancer has spread to the lymph nodes. And more often than not, we're finding breast cancers a lot earlier, and they haven't spread to the lymph nodes, but we're still taking the lymph nodes out because we have no other way of testing. So we're actually looking at the breast cancer tumors themselves, looking at the epigenetic changes, what genes have been turned on and turned off inside the breast cancer. And can we use that profile to predict whether or not people have disease in the lymph nodes or not without taking out the lymph nodes with surgery? So that is the gist of the research that the John Wayne family is supporting, which I think is really exciting, because if we can avoid overtreatment and all of the negative consequences and comorbidities and risks from unnecessary surgeries, I think that's a huge win for patients for sure.
Oh, I would think so. It takes me back to, Don Morton, who, sort of started shepherding my family in how to use my father's name to fight cancer. And, it goes back to his research in melanoma that led to the sentinel node biopsy technique. And so, I mean, how many years ago is that? Is that 30 years ago?
Yeah, just about. And
So 30 years ago.
yeah, for
But
sure.
that technology is now sort of dated, although it's still used. But your studies will advance that, because that also traced the lymphatic system.
Yeah, exactly. So I think it's actually apropos. It's kind of in continuity with what you've already started 30 years ago with Don Morton as well. We're just continuing the progress forward in terms of recognizing, I think in part, that disease in the lymph nodes for breast cancer is not actually a surgical disease. So we're learning more and more that you don't actually have to remove that with surgery in order for patients to be cured. And that's in part because there's so many other effective therapies nowadays. So if we can continue moving, sentinel node biopsy was revolutionary. And the fact that, your family had supported the research to to get this on the map has changed millions of lives, and we're trying to push it even a little bit further with your support, where if we actually don't have to take the lymph nodes out at all, or we can minimize patients who, so we do need that information, right? We need to know whether or not it went to the lymph nodes, but we're trying to figure out a way of getting that information without taking the lymph node out if you don't have to for cure. So this is looking at the epigenetics of the primary cancers to try to get that answer in a number of situations. So if we knew a patient had a positive lymph node, can we tell whether or not they had more than 3, which is a higher nodal stage? And we are finding that we can develop these signatures based on epigenetics that can tell us, do they have no lymph nodes? Do they only have 1 or 3 lymph nodes, or do they have 4 or more? So we can actually de-escalate our surgeries, and we can plan what kind of chemotherapy do we want to give based on the number of lymph nodes without actually having to remove those lymph nodes.
Wow.
So
That's
it's fun.
it also demonstrates that you never know, like okay, you're funding this guy and he's doing, research in melanoma. And
yeah.
and you may go, well, like, why? How does that affect other things? Well, that research in melanoma didn't work out great for melanoma, but it worked out tremendously well 30 years ago for breast cancer. And treating the people who have breast cancer, and now it's leading to other things. And maybe yours will take us back to tracking melanoma, because that's also a very difficult disease to follow.
Oh yeah, for sure. No, I mean, there so far nobody is looking at the primary tumors to determine lymph node spread based on these molecular profiles. And so I think, this is really exciting kind of field to pursue. And hopefully it'll be applicable to lots of cancers eventually, but we are starting first with breast because I think we continue to perform a lot of lymph node surgery unnecessarily for breast cancer patients.
Wow. I wonder if this whole swirl, all goes, like, we start distilling everything down. We go, oh,
Yeah.
this is all of them.
Yeah.
It's the work you guys do is so important, and it's so complex. I mean,
yeah, it is.
It's just, as a layperson who's just trying to figure out how to do something good, it's just amazing all the work that gets done in cancer. I think that we're circling, and we're gonna land on it soon.
There's a lot of smart people, not me, but my team who help with all these things.
Let's see. We talked about breast cancer. Some of the stuff is, we can be looked up. The median age, breast cancer is about 30%, 1 in 3 of all new female cancers each year. But haven't we really done some significant work in breast cancer compared to lung or other cancers? I mean, you guys have really made tremendous progress, and it's not.
For sure. Yeah. I mean, although it is now the #1 cancer in women, whereas lung used to be worldwide, it is the #1 cancer in women worldwide. The death rates from breast cancers have been progressively decreasing over the last several decades, which is wonderful. And that's due to obviously widespread screening, but also the more effective treatments that have been developed. But it is still, the most common cancer. And as you know, the numbers are almost reaching 300,000 a year now in the US, women who have cancers. But on the same vein, I think over 3.5 million women are currently alive with breast cancer. So we are doing, I think, a good job in terms of treating breast cancers effectively, which I'm really excited about.
Wow. There's a lot of discussion over mammograms versus, I guess, is it mammograms versus physical examinations, or is it just?
I'm not sure. I mean, I know mammograms
Am I the
have
right person to be talking to you about this? It feels
No, I mean, it's there are some critics about mammograms. Obviously, they say that they're not good enough and they have limitations. And while all that is true, and I think any imaging modality has limitations, it really is the only imaging modality at present that has been shown in multiple randomized trials to improve survival from breast cancer. So, I think mammograms definitely work. I think they do have limitations in women who have denser breasts because of the way the mammogram actually works. It shines the X-ray beam through the tissue. And if you have really dense tissue, it's like trying to shine a light through a brick wall, and that doesn't work very well. So we do have other imaging modalities to help with women who have denser breasts, but I still think screening mammograms are the way to go. They certainly catch cancers a lot earlier than a physical exam, because you're trying to find something when you can't feel it, or it's not big enough to feel. You can only see it because it's seen on imaging. So I still think mammograms and screening are very important. And I think they will catch cancer certainly earlier than if you didn't do routine screening and you just tried to find it by doing a self-exam or a clinical exam every year.
I see. Is there, you hear, like, if you take care of yourself, you'll avoid a lot of issues. And is breast cancer something that you can take steps to avoid?
That's a tricky one, because it's not like lung cancer where we know smoking causes lung cancer, or like cervical cancer where HPV, there's a direct link. There's not really a direct link with any one thing with breast cancer, except for things you can't really change, right? So one of the most common risk factors is just getting older. And as much as we try, we can't really fight that. And then the second one is just having all of this estrogen circulating around in our bodies. Those are the two most common risk factors for breast cancer, and we can't really change those. So the things that we can change, they're not necessarily specific to breast cancer, and it's not to say that stopping it is going to prevent you from getting breast cancer, but really the two things that have been shown to decrease risk are minimizing alcohol intake, and also just trying to make sure your vitamin D level is appropriate. So those have been shown in different kinds of studies to be linked to increased risk of breast cancer development. So as much as we can, yeah.
So like every kind of cancer, they say, if you're not eating a lot of sugar, you're getting vitamin D, you're exercising, you're doing these basic things for your health, they also are pretty significant in reducing the risk of cancers.
Yeah, I mean, I think so, for sure. I mean, I think there are a lot of lifestyle things we can do in general that can help decrease risk of any kinds of cancers, and those are the things that you mentioned. So I think trying to live a healthy lifestyle is good, but I will tell you, you can be the perfect person too by every cancer risk category, and you may still get breast cancer. So it's not 100%, but certainly you can try to help your odds with that. But specifically for breast, because breast cells have vitamin D receptors, et cetera, making sure your vitamin D level is appropriate, and that would be probably over, I think, about 50, and also reducing alcohol, because that has been shown to, in some instances, be a carcinogen. I think those things would be helpful if you're trying to be proactive.
Is the alcohol, is it the sugar in the alcohol, or is it something else? Is it
I
just
don't
the way
think
it
so.
affects your organs?
Yeah, I think it just can be a carcinogen in and of itself. It can kind of reduce DNA repair, and it can cause other molecular kind of changes that prevent our bodies from being really effective against fighting cancers.
How do you detect breast cancer? Like, obviously you'll have a mammogram or you'll feel something, and then you go to the doctor, and then how does that get confirmed? Is it always biopsy? Is it a blood test? Is it?
Yeah, right now it's always a tissue biopsy. So you're actually sampling the abnormality that's in the breast, and that gives us a lot of information in terms of, is it a breast cancer? If it is a breast cancer, what kind of a breast cancer is it? And then that tells a lot, well, how do we treat it then? Because we don't treat all breast cancers the same anymore. In fact, we've moved a lot toward targeted therapies and personalized approaches for patients, which I think have led to significantly better outcomes and reduce overtreatment for a lot of women too. So I think it does require a tissue biopsy at the moment. We don't have good blood tests to diagnose a cancer. We don't have tumor markers like PSA for prostate cancer and things like that.
I see. It's, you say breast cancer or prostate cancer, but there's actually different types of cancer if you have prostate cancer or breast cancer. And that one kind of was, I never liked that. That it was just one,
yeah, it'd be nice if they all had the same trigger that caused them, so that there's one cure for all.
And how do you distinguish between one and the other? And it's just years and years of treating that shows you that one protocol may serve you better than another?
Well, right now it's actually it's actually trying to learn more about what actually is making that cancer grow. So what we for a long time didn't really know, we couldn't find targets on these tumors. And even for the most aggressive kind of breast cancer that we treat now, something called triple negative, it's called triple negative just because it's negative for three targets or three markers: estrogen, progesterone, and HER2/neu. We haven't found the specific targets that drive that cancer to grow, though. But as we find more of these molecular targets, we'll be able to more effectively treat these cancers. So it's more about, I think, dissecting into the molecular features of the cancers. And then once we find a target, that'll lead to drug development to attack that target. And then it leads to the clinical trials to see if those medications work. But I think the first step is, looking at the tumor.
And then the tumor is always a group of cells that don't die and they keep multiplying, right?
Yeah,
Regardless
scary,
of
right?
which cancer it is. And so do things like do you think as a society obviously we're eating some highly processed foods and maybe we eat too much. And so is that overloading our system, its ability to clear out old cells? Like, does autophagy work
Yeah.
does that actually clear out cells that would become
Yeah.
cancer, or do we know?
Yeah, no, what we do know is our body actually has really great mechanisms for either repairing damaged DNA in our bodies, or if we can't repair that damaged DNA, it sends that cell down a pathway to die. So our bodies normally have ways of trying to maintain normal kind of processes that can control cancer. But when you have a problem in one of those DNA repair genes or in a tumor suppressor gene that's supposed to help fight cancer, that's when cancers can develop. So yeah, normally we do have ways of taking care of that inherently in our bodies. Our bodies are very sophisticated, but these things can be damaged by things that happen during our lifetime.
And what sort of things are you finding that really drive epigenetic causes in cancer? Is it sniffing gasoline when you're a kid, because you like the smell, or is it,
Yeah.
Lysol in the house? Like, do we know?
We don't really know. I think, though, some of the things that obesity is probably a big one. That can really change the epigenome of tumors. Likely a lot of toxins, although, these types of studies require large volumes of patients over long periods of time. So they're very difficult to kind of perform those types of studies, looking at behavioral things that cause biologic changes in the body. But we try to look more specifically, in observational studies, et cetera, to try to find these links. But, it's hard to really say, and it's hard to even really know if it's any one thing. It could be a combination of different things that then cause these specific epigenetic profile that will then, cause a cancer to form.
So steer clear of as many chemicals as you can.
I would say so. I mean,
Keep yourself fit.
yeah, I think,
Restrict your eating a bit.
yeah, I think so. I mean, I think trying to, avoid processed foods, artificial sweeteners, sugars, all of those types of things are good. But I do think also things in moderation. I don't think you have to be fanatical about it necessarily, but just trying to be smart about it.
I'm just fairly fanatical about whatever.
Good for you.
Good luck. Any thoughts on does anything give you heartburn when you hear of the US not banning certain types of food that other countries are banning? Like, do you think, gosh,
Yeah.
is this going to affect us? We have no idea, right?
Yeah, I mean, there's a lot of things that I always wonder that I have no idea. I mean, why is the incidence of breast cancer going up in women under age 40? And it's not skyrocketing, but it's definitely increasing among younger women. And then I have to think, well, what's happening in this generation now? They all have iPhones, they've all got computers, they've all have, electronics. And does that weigh in at all? I don't know. I mean, you might think so, but none of the data shows that at the moment. So you just have to wonder.
Yeah.
It's hard to
Yeah.
know.
And there are a lot of chemicals in our daily lives, which is
Yeah,
kind of scary.
yeah,
And the food thing always, it just always bothers me, that certain companies are allowed to push things through that
yeah,
if you just use your common sense, you'd go, oh, I'd rather not eat that one. Just the regular one would be fine. I don't know.
yeah, yeah.
I don't know. I don't know. Anyway, do the surgical techniques change over time? Like from, when Armand and Don were doing the sentinel node and doing surgeries to you today, how is it different or is it very similar?
Well, we're certainly, because our success rates have improved significantly and patients are living a lot longer, I will definitely tell you we focus much more on the aesthetic aspects in addition to the cancer aspects. So I would say in the old days, the thought was that you should feel lucky that you're alive, right? That was kind of how patients were made to feel. And I think now we recognize that, it's our responsibility not only to treat the cancer, but to make sure the woman feels, very much like herself and as whole as possible after treatment is done. So we've moved a lot toward oncoplastic surgeries, aesthetic surgeries. So there is a component of that in all of the breast surgeries that we do. And obviously, the cancer part is always number one, but we don't forget about or disregard the aesthetic component for patients as well. And another thing that's kind of on the horizon that's exciting is we just opened a clinical trial here at Duke where we're one of a group of institutions that is starting robotic nipple-sparing mastectomies using the robot. So
Wow.
we're going to be starting to do that for breast surgeries as well. And hopefully that way we can see planes more clearly. Patients will get, potentially we can try to do some preservation of nerves for the skin, et cetera. And also
Wow.
just to have, less complications from the surgery in terms of skin dying, nipple dying. So I think it's exciting.
All that is really important to people. You guys are, you do incredible work. Is there, I had, a little spot on my cheek and it turned out to be melanoma.
Oh my
And it was
gosh.
like I would have never had it checked. But they have to go in and take out a big circle and they're like, well,
Yeah.
do you want a plastic surgery? And I'm like, oh, whatever, just take the thing out. They had a plastic surgeon there. But that was the
That's
aftermath.
no.
Uh, it was
You can't even see anything on your face.
pretty significant. And the guy did an amazing job.
Yeah, I can't
My
see a thing.
whiskers are all rearranged when I shave. It's different.
So
But
now your beard is up here.
there's an example. If it was on my back, it wouldn't have made a difference. But since it was on my face, they brought in a doctor, and I thought he did a spectacular job.
Yeah, yeah. And I don't think patients should be made to feel like they can't have that. That if they want to cure the cancer, they have to suffer the consequences aesthetically. Sometimes there are things that we can't help because the cancer is too
Sure.
progressed or something.
Yeah.
But most times when it's early stage, we, have the responsibility, I think, as their providers to do the best we can to restore them back to whole after surgery. So that's a big part now.
Is there anything like it, obviously you want to go to a specialist, right? If you're in an underserved area, you want to travel and go find somebody who knows what they're doing. But other than that, is there advice that you'd want to give to somebody who's recently diagnosed with breast cancer?
Well, I do think that's really important to have a specialized team who specializes in breast cancer because I think the more that you specialize in a certain area, the more opportunities that the patient will have for treatments and cure. But also, I just want patients to know that I think they should feel very hopeful that they got this, that, with all the decades of research and where we are now, I think most women should not be afraid that they can't beat it. And I want them to all stay encouraged and to know that, cure rates for breast cancer nowadays are I think they exceed 90%. So I think it's very, very good overall.
Amazing.
Yeah.
And you're definitely going to see a surgeon at some point if you have
Mhm.
breast cancer, correct? And that's one thing that my family and I are very proud of, the Surgical Oncology Fellowship Program. You helped train some of our fellows, and we're thrilled that that keeps going. I think we have almost 200 graduates from that program. And so if somebody's out there listening to this and they want to figure out where a fellowship trained surgeon is, they can come to John Wayne Cancer Foundation's website, and we've got a map of where everybody is and what their specialty is, and you're free to reach out to us to try to find the best place for your treatment, and we can guide you to people like Dr. DiNome here. Well, Dr. DiNome, we're proud to support you. We're always thrilled when we get to hear from you and have a conversation with you. And
Thanks, Ethan.
we look forward to your continued success and the relationship moving into the future.
Yeah, thank you so much. I love you guys. You and your family have done so much for patients, over the last several decades. And I don't know if you really know how much you've impacted people, but I see it every day because of what I do. We do sentinel node biopsies on most everybody who would have had to have full lymph node surgeries, full lymph node dissections, a couple decades ago. So, I see it every day, and I don't know if you know it. I hope you do, you and your family, that you know it, that you've really made a tremendous impact on so many women across the country, and men too with melanoma. But I do hope you know that.
Well, thank you. We're able to do it because we found people like you to support. None of us came up with the sentinel node or any of that stuff.
Well,
We're
you
just
supported it. Yeah.
Yeah. All right, Dr. DiNome, thank you for your time.
Thank you.